This talk will be about my knee dislocation and multi-ligament practice, for which I look after the southern half of Western Australia. Most people will not have seen Australian rules football. Everyone focuses on the left knee there. So this is an Australian footballer who had suffered a knee dislocation, a four-ligament injury, and certainly the majority of patients that I treat are actually athletes with high-level multi-ligament injuries. In terms of my mantra, individualising surgery is crucial. Tailor your operation and your skill set to the patient's individual needs rather than have a narrow skill set that the patient just has to accept. And we have to look at risk factors, the type of sport, what other injuries they have, and then we have to look at donor site morbidity and the like when we're discussing graft choice options. Most of us are aware of the Schenck classification that assesses knee dislocations, and this is helpful to assess extent of injury, and certainly from our point of view as a research tool as well. So what is my treatment algorithm when we discuss knee dislocations and multi-ligaments? Diagnosis and reduction. Be aware of the low energy missed knee dislocation. Early reduction and neurovascular assessment is crucial. We have a very low threshold for CT angiogram if it's available in your institution. Otherwise, an ankle brachial index of less than 0.9 is a concern. Look at the common peroneal nerve, and in our series, 20% of patients have a common peroneal nerve injury. Patients must have early range of motion. We almost never put an external fixator on our patient unless they are irreducible, it's an open injury requiring it, or they have a vascular bypass that our vascular surgeons demand an X-fix. But more and more, we work with them to not require one at all, even with a vascular bypass. And I want to be performing early, single-stage, multi-ligament reconstruction. So we get our patients moving early, they must have full extension. So this patient on the table worries me, and at least 110 degrees before we progress. So why do we do an early single stage? Well, we want to get maximum early stability with one rehab period. We want to restore that joint and allow appropriate soft tissue healing to correct the tension and minimise that abnormal load. And we know early range leads to less stiffness, neuromuscular control, and better chondral nourishment. But it's not just early range, it's also post-op. I see so much literature where patients are braced for a year post-op or have inordinately slow post-op recovery. Your surgery needs to allow the patient to get moving early. Making a plan is crucial. There is no role for diagnostic arthroscopy in these patients. The history, your examination, and the early scan allows us to determine what we need to do. Graft choice is crucial, and have an array of mostly autograft in my system, but also allograft and synthetic if it's available. The order of events, prioritise the cruciates, and the PCL is your key. That's your cornerstone where you reset that tibial station and everything else works after it, and then try and repair as much as you can, and then reconstruct to splint your repairs. And here we can see all the various grafts that we use. So what are the key points here? Take away time pressure. I don't use tourniquet for my multi-ligs. I use tranexamic acid, Marcaine and adrenaline in the knee, and bags with adrenaline to try and minimise my time pressure. I use a Werewolf ablator. Good team, not just a good team, but a great team. So I'm lucky to have my fellow and my registrar with me and a great staff. Though I must admit the staff that I had in the operating theatre were as good, if not better, than any I've had ever before. X-fix, I said almost never. Out of our last 100 knee dislocations, we've put on one X-fix. And the indications I mentioned are those there. So what's the order of events? Setting up is crucial. I drape both knees if I need contralateral graft, have all the equipment available in a nice theatre with image intensifier, which I'll always use for my PCL every single time, and space to get under the table. We'll prepare the grafts first, so hamstrings from one or both knees, quadriceps tendon, and then have our allograft available. I mentioned the cruciates first. So what's our order? I'll scope the knee, I'll do my femoral PCL tunnel, then my femoral ACL tunnel, then my tibial PCL tunnel, and then I'll fix that, and then my tibial ACL tunnel and fix that. I generally, if it's a foreligament injury, will move on to the posterolateral corner, because by that time we're 2 or 3 hours in, and I don't want to be too tired when I'm there trying to dissect the nerve out, which must be found every single time. We'll find the structures that Sachin has shown us and repair those, and then I'll move on to the posteromedial side. The key on the posteromedial side is, for me, it's always different. Isometry is crucial, and it really, sometimes it requires 4 or 5 goes to get my MCL tension right, so don't rush that one. So this is what we always do. We've got a whiteboard in the operating theatre, setting out what our order of events is, setting out what our plan is, so again, when we're several hours in, we understand what we need to do. Drape bilaterally, lots of space, including the image intensifier and our various grafts. Now, anatomy is crucial. So here you can see a dissection of the posterolateral corner, and often it's a train wreck, like we can see here. This common perineal nerve had taken a very tortuous path, and particularly when there's a fibular avulsion fracture or when there's a biceps injury, be aware that common perineal nerve anatomy is extremely abnormal, and you have to move mostly proximal to get into the normal zone rather than right at that zone of injury. Understanding that lateral-sided anatomy, again, which we've seen a great display of, is really crucial to ideally get that great reconstruction. Now, this paper, which Andy Williams gave to me as a fellow, helps us understand that ideal position of the common perineal nerve, 2 finger breadths proximal to the fibula as it exits beneath the biceps. Unfortunately, in most of the multi-ligs I see, it's never that simple. And on the medial side, again, I can't emphasize enough how important it is to get isometry right, and I generally use a Y-shaped reconstruction, although more and more my short limb is anterior as per Andy's work rather than posterior. In terms of rehab, move, move, move. That is crucial. It is my responsibility to be able to get these patients moving. We want to get them weight bearing as quickly as we can. For me, 2 weeks flat foot touch and generally never more, and then although I keep them on crutches, it's all about gait normalisation. I want them walking. My range of motion, 0 to 60 for the first couple of weeks, and then I get them going. I want them at 90 degrees by that 5 to 6 week mark, and unrestricted full range by 12 to 14 weeks. I do not like long bracing. And again, in our PCL session tomorrow, I'll talk about this. I never will brace someone for longer than 10 weeks because the impact on their muscle atrophy is huge. So now to run through a few cases, and again, this is Australian football. This is a tackle in Australian football leading to a knee dislocation. Complete KD4P with a common perineal nerve. This is what we saw: PCL blowout, ACL blowout, complete medial-sided and lateral-sided injury with that common perineal nerve. 6 hours of surgery later, this is what we did. So foreligament reconstruction. I do use metal fixation, generally to help me with my II to prevent canal convergence, but also to help me understand what I'm dealing with later on. And this will be a message I'll re-emphasise over the next few minutes. Particularly in athletes, you can get these patients back to sport. And I'll show our series in a moment that shows that it's quite remarkable. If done well, this surgery can actually do as well as a primary ACL reconstruction. So what about case 2? This is one of my favourite patients. She was a professional Australian footballer and a police officer. Christmas Eve 2019, a stolen car tried to take her out. So intentionally hit as a pedestrian by a stolen car. This is her. She was about to have her debut season as a footballer. She was ruled out. Bilateral knee dislocations. On her right knee, she had a PCL, an ACL graft rupture, so she'd previously had a reconstruction, a lateral root, and a posteromedial corner, as we could see here. And on her left side, a KD1 with an ACL and a posterolateral corner. So this I staged. I did her better knee, being the left knee first, and then 6 weeks later did her right knee. This is what we did on the right knee, revision ACL using a quads graft, PCL, posteromedial corner, and that lateral root, which we see there, all single-stage surgery. Remarkably, she got back to play professional Australian football at 18 months following injury, and this was her in her debut game. So what about the unlikely wins? This player here was a professional basketballer with an ACL posterolateral corner, which we can see that complete blowout there, and a complete common peroneal nerve injury that required a nerve transfer. He had an ACL posterolateral corner injury and a nerve transfer, and remarkably, this chap had actually just signed his first international contract in Germany. We got him back to play back in Western Australia, and then his German team in Freiburg has recontracted him 4 months ago. And seeing a note like this, where he never thought he would play basketball again, and in fact he's been able to get his professional contract back, certainly makes our job worthwhile. What about sport? The literature is very sparse, and we're just about to publish our series of athletes with knee dislocations. It's actually quite remarkable to see that both PROMS and TEGNA, so their return to sport, shows that these athletes get back at the same level and same rate as my isolated ACL cohort. The difference is they just take longer at 18 to 24 months rather than 9 to 12 months. So don't sell the doomsday story. As athletes, they can get back. Obviously different for a high energy motor vehicle patient, but for athletes, they can do well. So the final case to finish off is this one, a big wave surfer south of Perth. This patient dislocated his knee, landed on the beach, and one of my previous multi-lig patients who'd had a 4 ligament injury was actually on the beach 2 years following his and said, "You need to see Pete, he'll look after you." I got a call at 9 o'clock on a public holiday saying, "I've got a knee dislocated 3 hours south of Perth, can you help?" So this is what he looked like. And I think understanding the EUA is crucial. So assessing his hyperextension to start, so we can see 10, 15 degrees of hyperextension, showing that big posterior capsule PCL injury. Looking at the draw, again, proper grade 3 PCL here. Anterior draw wasn't too bad, and certainly when you're looking at your anterior draw, but certainly grade 2, make sure you do it from neutral, not from a posterior station, otherwise it will always look a lot worse than it is. He's got a high grade Lockman. We look at his collateral, so the medial side first. So big medial sided blowout we can see here, so proper grade 3 MCL. When we look at his LCL, again, there's always, I find, slightly less on that lateral side because of the splinting of at least some of the structures that are intact. And then finally, when they're in the operating theatre, I'll do my dial test while they're supine. And we can see huge asymmetry, both at 30 degrees of flexion and at 90 degrees of flexion, consistent with that PCL and posterolateral corner injury. So this is a full house knee dislocation in a surfer, and big waves, that's 25-foot waves. So this is just over 6 hours of surgery, and this is again what we did, single stage, 4 ligament reconstruction, and I'm pleased to say he's back surfing those big waves at the 20-month mark. So these are just some of the cases. These are all done over the last 8 months. No dislocation is the same, no operation is the same, which means that planning is crucial. So what are my take-home messages to unlock the enigma of knee dislocations? Firstly, they all need teamwork, and I'm very proud of the team we have in Perth. They are all different, and you have to have a really good think with your planning to understand how you can do it all at once, how you can get this patient back, how you can get them moving early. Take your time, but certainly ideally do it all. Have all the equipment that allows you to achieve that patient getting back to what they want to do. That early single stage reconstruction very much works. Thank you very much, and thank you again for having me at this great meeting.